The HURLEY as part of its commitment to help training young investigators, provide support for 4 PhDs in the conduct of primary methodological research. These are spread around the partners institutions that are working with the TMRN. And what we're now going to have the pleasure of is a whistle-stop tour from the 4 PhDs, starting with Caroline Hurley, who's working with us down in Cork. Just giving a brief 10-minute display of some of the work that they're doing as part of the PhD. Just in the interest of time, we're not going to have a question and answer session as part of this, but the candidates will all be available afterwards for questions if anybody has them. Caroline, it's over to you.
Hi, good afternoon everyone. As Joe said, my name is Caroline Hurley. I am a first-year PhD student with the HRB TMRN network, and I'm based in the Epidemiology and Public Health Department in UCC. So today is going to be a brief overview of my PhD, which is looking at risk-based monitoring for clinical trials. So what I hope to cover in the next 5 minutes is just a bit of a background on the emergence of risk-based monitoring and why it has come to the forefront and kind of is now regarded as the effective way to monitor a clinical trial or the future of monitoring clinical trials, and also to discuss what I hope to add to the area of risk-based monitoring over the next 2 years. So I suppose for anyone who is involved in clinical trials, they'll be familiar with the ICH GCP guidelines. So these guidelines, they're really kind of legally binding instructions on how a study should be conducted, very much from its development right down to how you should analyse the results. And within these guidelines, there are certain stipulations on how you should monitor a clinical trial. So I suppose under GCP, it requires a study monitor to ensure that a patient remains safe, or their safety is kind of remains during the course of a clinical trial. Also, that the data you collect during the study is accurate and reliable, and that the clinical trial complies with GCP requirements and any regulatory requirements that relation to that study. So I suppose in response to this GCP requirement, traditionally clinical trialists have implemented kind of a 100% on-site source data verification type of monitoring to monitor the studies, which is very much a paper-based monitoring process and very reactive. So if a problem is identified during a monitoring visit, then an action is taken to, I suppose, solve that problem. So just again back to traditional monitoring, it kind of has been coined as a one-size-fits-all approach. So it doesn't have, I suppose, different instructions for how different phases of study should be monitored, and also how different study drugs should be monitored. It kind of is a one-size-fits-all that every study, regardless of the risk, should be monitored to comply with GCP. So I suppose this is just an example of, I suppose, the GCP guidelines. In reality, these 2 studies, this TRUST study and STRIDER, they're being undertaken in UCC, and both studies have very different study populations and investigating very different study drugs. But I suppose going back to GCP and traditional monitoring, it wouldn't instruct that both these studies, regardless of risk, need the same amount of monitoring. So recently, I suppose there has been kind of global criticism of this traditional monitoring. So some people believe it is very costly and not extremely time efficient, because someone has to travel to a study site, go through hundreds of paper records and identify problems if they are there. So again, following on from these criticisms, there have been kind of a global move to improve how studies are monitored, and to kind of look at a clinical study as its own entity as such, that every study is unique, so every study requires its own kind of monitoring process. So in relation to, I suppose, the need for improvements, the future of clinical trial monitoring is really focused around this type of management system known as risk-based monitoring. So risk-based management would have been, I suppose, is very common to the area of construction and to business, but they want to take these elements of management and bring them into how we monitor clinical trials. So I suppose this is kind of the future of clinical trial monitoring that has been promoted and supported by the FDA and the EMA. So both of these, I suppose, experts in clinical trials, they have advised clinical researchers to move away from traditional monitoring and to adapt this new risk-based approach to monitoring. So it is extremely supported, I suppose, by the leading experts in the area. So going back again to where we began to risk-based monitoring. So for those who aren't aware, it is really more a technology-based approach to managing a clinical trial. It incorporates both on-site and centralised monitoring, but the level of monitoring is dependent on the risk of that study. And also, it really is a proactive approach. So you first go through the protocol, identify risks, and then you determine what type of monitoring you need. And again, I suppose with risk-based monitoring, and from reading around the literature, there still is a lot of confusion regarding the definition of this term. It is in itself, it's more of an approach that can be kind of used as an umbrella term that incorporates all types of monitoring methods under it, but the level of monitoring depends on the risk of the study. So how do we develop a risk-based monitoring plan? Well, first we need to assess the risks involved in each study. So some of these risks would be the study drug, the study population under investigation, characteristics of the study team. And in order to assess the risk, you need to apply what is known as a risk assessment tool, which is basically a checklist. So the MHRA have developed this type of checklist. So it allows you to go through your study protocol, look for the risks, and then at the end of the checklist, you can kind of give a level of risk to your study, so type A or type B, and then you can kind of continue on and determine what type of monitoring you need, relating back again to the risk of that study. So I suppose, so going forward, despite the big promotion of risk-based monitoring and the development of some of these risk assessment tools, there still is great uncertainty on how we should be implementing risk-based monitoring, and also if it really is the most effective way of managing a clinical trial. So this has led to, I suppose, the need for my PhD. And one of the main objectives on my PhD is to develop a risk assessment tool that can be used by Irish academic-led clinical studies. So kind of tailor-made tool that is suitable for the needs of Irish academic clinical trialists. So going from this need, I will be conducting an electronic survey, just an Irish survey, looking at what is currently being conducted by the academic clinical organisations such as the CRFC and the one based in NUIG, just to see what people are currently doing in terms of monitoring, if anybody is conducting risk-based monitoring, and also how they use certain risk assessment tools. And then also just to determine, going forward, what do clinical trials in Ireland want to see from a risk assessment tool? Do they want it to be paper-based, electronic-based? How many question items do they need on that checklist? So many of you might be receiving this monitoring survey in the 2016, so please do participate. So that's kind of everything for me today. So again, I'm looking at risk-based monitoring with the main objective of developing a risk assessment tool to guide the future of risk-based monitoring for Irish academic-led studies. So I just want to thank the HRB team for their support, and my supervisors, Professor Joe Eustace, Dr. Evelyn Shiley, Professor Patricia Carney, Dr. Evelyn Flanagan, and Professor Mike Clark. So thank you.
Thank you very much, Carla. And as you'll notice, to make this especially challenging, the speakers have no control over the timing of the slides. It's interesting, his approach is called Pecha Kucha, which sounds like a Chinese torture, which probably represents what it is. We next have AISLINN Conway from Galway.
Thank you. I'm just coming up to my anniversary of my first year of the PhD, and I'm just going to talk in really broad terms about what it is at the moment. So in 2010, I moved to the UK and began work for the NHS as an evidence-based information specialist. And it was my job to disseminate evidence to healthcare professionals in a large teaching hospital when they came to me with patient-specific questions or broad clinical topics, and sometimes corporate questions as well. Doesn't seem to be moving on. Just use the pointer. Okay, yeah. Easier. Okay.
Space channels.
Okay.
What's on my time?
Okay. So when I was looking and doing searches for this evidence, some was very easy to find and some was less easy because there was a lack of evidence in particular areas, and sometimes when we found the evidence it still raised more uncertainty, there was consistencies and conflicting studies. So I was always very relieved when I found an applicable and relevant and up-to-date systematic review, because they're known to be the so-called gold standards of research. However, not very long into the job, I realised that the healthcare professionals were not always engaging with them and using them in their patient care and decision making. Earlier on today, Professor Craig Ramsay talked about knowledge translation and the knowledge to action gap, and this is similar to the research to practice gap. So really, I wanted to explore why exactly they possibly weren't using the resources, what the reasons were. So being on at handover with them and ward rounds and grand rounds, we would get talking about their use of resources, and they would say that they didn't have enough time to read a whole systematic review, it would take too long, or they didn't necessarily feel that they had the statistical background to understand the findings, or so many of the systematic reviews, I suppose, highlighted gaps in the evidence as well. So really, at that stage, I began thinking about, okay, how can we actually disseminate the findings of systematic reviews to them so that they can use them in their daily practice. So the ultimate aim of dissemination is user utilization, and that's really the focus of my PhD. I want to investigate methods of dissemination that will encourage healthcare professionals to use systematic review findings. And dissemination, it doesn't happen spontaneously. The strategies can be divided into passive and active. And passive is like mass mailings or presentations to heterogeneous groups, whereas active is more focused. It might be point of care decision tools or mass media campaigns. There is evidence out there that passive methods aren't really useful, so we want to investigate the active ones. And also, when designing dissemination strategies and looking at methods, you need to decide whether you want to just communicate a single message or be more comprehensive and take a wider approach. So there was a systematic review about improving the uptake of systematic reviews conducted by Wallace and his colleagues in 2014, and their main findings, so that he found 3 interventions that were actually statistically significant and worked. And my PhD is more focusing on number 2 and number 3 here, in particular number 2. Again, Professor Craig Ramsay talked about the importance of context, and Jessica, who will be speaking after me, will talk about it in more depth as well. But just to really emphasize the importance of it for methods of dissemination, because you can have a great method and you can have a lot of evidence behind it, but if there isn't the organizational readiness and conditions and training and resources and supports, it's just not going to work. So I'm going to talk about 5 different methods of dissemination now, all aimed at disseminating and summarising systematic review findings. So the importance of social media, you'll see as I go through them, they all make use of some form of social media. So it's great for pumping out messages and research findings to not only healthcare professionals but to the public and so forth. So the first one is the blog shot. This is from Cochrane UK, and it's been developed a lot by Sarah Chapman and her colleagues, and evidently Cochrane at the moment. And this is basically it. So it's a short message about a Cochrane review, or a short couple of sentences. Then it tells you what the evidence is based on. It actually grades the evidence using the grade criteria, and then it provides you, importantly, with a link to further information. So if it's hooked your interest, then you can click in and find out more. The next one is video abstracts from the BMJ. So when authors are publishing with the BMJ, they'll often be invited to submit a video abstract, and they're a new way, and so they're uploaded to YouTube, and it's like a repository of some of their publications. The next one is the summary of findings table, and this is one I've taken from the DISSEMINATIng website, and it's an interactive summary of findings table. So it actually goes in layers. So the first layer is the more basic information, and then you can click in continuously until you can get to the level of information that you need. And I'm currently doing a systematic review on summary of findings tables. So the next one is podcasting. So Lisa McGuire and Mike Clark have done a lot on the potential of podcasting, also known as audio summaries, for disseminating research and systematic review findings. And the final one is an infographic, and this is by Dr. Carlos Coelho, and it's information and graphical representation of the findings of a Cochrane review, and this is up on Visually Cochrane, this on a blog. So basically that's the focus of my PhD, the various methods that I will be investigating, and hopefully helping people traverse that research to action gap that they might feel, because everybody needs a little help along the way. Okay, and I'd like to also thank the HTMR and my supervisors, Professor Mike Clark, Professor Declan Devan, and Professor Sean Treweek. Thank you.
Thank you, Aisling. And following on from Professor Chandler's talk, we're obviously using alternation with regard to the control of the slides. This may well be an example of a study within a trial, but that's questions afterwards. The next speaker is going to be Jessica Dowd from the Centre for Global Health in Trinity College.
Hi, welcome. My name is Jessica Dowd, and I'm a first-year PhD researcher with the HURLEY based at the Centre for Global Health in Trinity. So today I want to give a brief overview of context and why context is important in healthcare interventions, and give a brief overview of realist methods, which is the methods I'll be using in my PhD, how we can start incorporating context more into healthcare research. Just a little bit of background on how my own interest came in context is I'm a clinician working as a physiotherapist over the past number of years, but I've worked across a number of different countries in a number of different settings, and I found through working in different health systems with different human resources, different staffing, and individuals from very different backgrounds, there's a lot of differences in how interventions were engaged with and how they worked. However, when I look back at the research, that wasn't really reflected in that. Everything was very much randomised control trial based, where context wasn't really mentioned at all, or how things work differently in different places, which led to the interest in working in methods that would start to look at that. Part of the thinking, part of the reason I think context hasn't been looked at a huge amount is that context is really difficult to define. So in essence, context is everything around us, but by saying that, it's really difficult to pinpoint exactly what it is. Some of the implementation frameworks that Craig Ramsey spoke about earlier have started to make a bit of headway towards what is context and what is context in healthcare settings. And my PhD will start to work a bit towards finding out more factors that influence it. But some of the key ones are individual factors around that person, their experiences with the health system, their motivation, their cultural beliefs, the health system itself, a hospital setting, community setting, the human resources, their experience, their motivation, whether there's high levels of staff turnover, how ready they are to engage with programs will make a huge difference in how that program is engaged with in that setting. And then that's not even to mention kind of the wider contextual issues, the geographic issues, the political issues, the economic and financial issues as well. And things such as like equipment and resources all play a huge part in the effectiveness. So I just wanted to use a quick example of how context has implications on the effectiveness. And Patricia Crowley was brought up by Ian Chalmers there, and again she did the review, which is the Cochrane logo itself. And this looks at the use of antenatal corticosteroids for people at risk of preterm birth. And that review findings and subsequent reviews found that a single course of it was effective in reducing risk of neonatal mortality by 30 to 50%, so really effective. The issue with that is these studies are all carried out in high-income country contexts, and a recent large-scale clusterised randomised controlled trial carried out in 6 low middle-income countries of over 98,000 births found that use of steroids was not found to be effective, and in some cases actually reduced the risk of neonatal death and maternal infection. This study then hypothesised that it was the contextual factors which led to this, so around diagnostics, diagnostic equipment, around human resources, around their experience of diagnosis, on top of having neonatal intensive care and adequate care services for birth. So off the back of that, the WHO put out guidance saying to use steroids, but only when the context facilitates it. So I think that's really important, just to recognise that things, the assumption that things will work everywhere, it might not necessarily be the wisest, and we always need to consider the context that we're going to apply things in. So I just wanted to move on then to realist methods. So it's a methods of looking at things in real world settings, and instead of trying to remove context or avoid it or pretend that it's not there, it really acknowledges that context is there, and it explores that as part of the research. So in realist methods, it looks at your outcome. So you're still looking at your outcome data. That could be quantitative, qualitative, whatever suits your intervention or your program. But it's also looking at what contextual factors might be affecting that outcome and how they're affecting it. So you're looking at your context plus your mechanism equals your outcome. So the CMO you'll often hear about in realist methods. These methods have been around since the 1990s, so they're not new, so Paulson and Tilley put them forward. However, in the last few years, they started to gain a bit more traction, particularly in healthcare as well. Part of the reason being they've released reporting guidelines and reporting standards in 2013 for realist review. So again, once that comes into fore, then people have a bit more guidance on how best to carry it out. So realist methods come in the form of meta-narrative reviews, realist reviews, and realist evaluations, which are looking at an individual program. So my PhD will be doing a realist evaluation of a number of programs. So I think anyone that's worked in clinical practice knows that an RCT is trying to control for everything, but in the real world, that's not what happens. I think one of the main benefits of realist methods is that we're starting to acknowledge that. We're looking at things, how they are in the real world, whether they're working or not, and how they're working. So I think one of the key benefits of that. Also, I think it just gives the information that people need. So very much when we look at what policymakers, what information they want, patients and practitioners, they want to know, will it work in their setting? So it's great to get systematic reviews and information on randomised controlled trials. But if you have a study that's in a setting very similar to yours and it said, it's worked in our setting and it's worked because of this in this way, that's really easy information to take and then decide whether or not to implement it in your setting. Again, it could be the opposite. It could be that's worked in a setting that's completely different to ours, so I'm not sure if it will work, or we have to adapt the intervention or adapt our context in order to make it fit. So just moving forward, I think part of the HRB TMRN aims is to make research more relevant, accessible and influential, and I think incorporating context and real-world settings into research is really important. So the future of my PhD is to carry out 2 or 3 realist evaluations of a rehab intervention, which is rolled out multi-country, so across 3 different country contexts, and seeing whether the interventions worked or not and how the context influenced that. So thanks very much for listening. The sunset is a sign to close it down. But thanks for listening. And again, thanks to the HRB TMRN for all their support, and to my supervisors, Dr. Fiona Larkin at the Centre for Global Health in Trinity, and Professor Eilish McAuliffe at UCD School of Health Systems, Nursing and Midwifery. Thank you.
Final speaker is going to be Lydia Emerson from Belfast.
Just to start the slideshow.
So I've been invited here today just to give a brief overview about my PhD project. My entire study is based on process evaluation. So what I'm hoping to do by the end of my 4-year MRC fellowship is develop a framework that anyone can use to conduct a process evaluation of a complex critical care trial. So complex interventions, well, a simple intervention, if you want to think maybe about a very straightforward drug trial where the protocol is followed, and at the end of that study, if you ask the question, did it work? Well, it's a very straightforward answer. But a complex intervention, it has multiple interrelated components, and I've used these cogs just using some of the components of an intervention I'm currently evaluating. So these component parts, they interact with one another, and it can be very difficult to actually disentangle their effects. Complex interventions are very often used in the field of health education, and that's because it's not just about the package or the intervention that's put into the setting, but the results are very dependent on maybe the person who delivers it, their skills in doing so, the setting or the context in which we set the intervention. And it's also very dependent on how much is delivered, so we call that the dose. Is the intervention actually delivered as it is intended, or the fidelity? And a complex intervention can only be effective within a setting if all these component parts here work together in sync. So process evaluation, it looks at all these component parts. It wants to find out what worked well, what worked poorly, in what context do things work particularly well or not. And by conducting a process evaluation, that really lets us unpick all these trial components. And we do this by these 4 steps. So we document the setting characteristics. So like I said, it's very dependent on the context we set the intervention in. What are the resources within that setting? What's the current workload? What are the attitude of the staff or the clinicians who have to actually use the intervention? Then we look at examining how the intervention is implemented within a unit. So how was it introduced into the unit? How did staff actually get to know about it? Were they trained to use the intervention? And how did they actually get to grips with it? Then we look at how it was delivered. So who delivered it? Was there fidelity? Was it actually delivered as it was intended? Or maybe did they actually leave some parts out? Then we look at the receipt. So, like for example, if it's an educational intervention and it's maybe a 6-part program, did people turn up for all those classes, or maybe did they just turn up for some of them? And if they did, how did they actually receive that intervention, or did they engage with it? Now we want to elicit information on the barriers and facilitators to the intervention adoption. So what things within a particular unit maybe facilitated it and running particularly well? Was there anything that blocked it from working? Were there barriers? And this is very important for later down the line when we want to know what was found, and we can avoid the barriers but hopefully implement those facilitating factors. This will all then be used at the end of the study to explain the trial outcome. So, for example, if we're testing knowledge after an educational intervention and people score maybe very low at the end, well then by doing a process evaluation we'll be able to answer the question why. Was it the content? Was it the setting? Was it how individuals actually engaged with it? And this is particularly important in multi-site trials where the same intervention is subject to vast variation in how it's implemented and received. So there's 3 key aspects of doing a process evaluation, which I've already alluded to. The first one is the fidelity, and that's the adherence to the components of the intervention. So do people actually stick to what they were supposed to do, and how true were they to adhering to all the components of the intervention? Secondly is the dose, so how much of the intended intervention was actually delivered. So like I said, if it's a health education intervention and it's a 6-part program, were all those parts delivered, or maybe did they only deliver 3 or 4 parts? And finally, the reach, the proportion of the intended recipients who actually participate in the intervention. So how many people essentially got the intervention that were supposed to. So how's it done? Well, it's been done in many ways, but people are now specifically starting to look at fidelity, dose and reach. So the MRC framework for developing and evaluating complex interventions was published in 2008, but there is no detailed guidance within that document on conducting a process evaluation. Now there's new 2014 process evaluation guidance from the MRC, and because funders are investing so much now in clinical trials, they are really asking the question why interventions do or do not work, but there are no answers. So we need to robustly collect all the information to give the answer. And I've systematically searched the literature, and I can only find 2 studies within critical care described as process evaluations. So we now know that clinical trials have different components, and funders recommend that if there are multiple components, then we need to carry out a robust process evaluation. But as I've said, there's no critical care clinical trial that has yet had a process evaluation conducted alongside it. And this is the basis of my PhD, which is to design a process evaluation framework for understanding the factors that impact on the successful delivery of complex critical care trials. And what I would like to be able to tell you in another 3 years at the end of my study is that I have a framework which anyone working within a critical care environment can use when they're conducting a trial of a complex intervention. Thank you.